Hi, I'm Corey Langer. I'm the Director of Thoracic Oncology at the Abrams Cancer Center and Professor of Medicine at the Perelman School of Medicine at the University of Pennsylvania. So it's my privilege today to talk about the metastatic lung cancer. I was the last discussant of the meeting. I'd like to say they saved the best for last, but certainly saved the most controversial and probably most comprehensive topic for last. We've seen a tsunami of studies in the last 5 to 10 years, particularly in the last 2 to 3 years, that have firmly established the role for immunotherapy in advanced non-small cell, either alone in those with high PD-L1 expression or across the board, regardless of PD-L1 expression, using combinations of immunotherapy and either chemo or combinatorial immunotherapy approaches. None of this was available 5 to 6 years ago. So for the majority of patients with advanced non-small cell who have what I call wild type disease, who don't have an oncogenic driver, immunotherapy is the standard of care. For those with 50% or higher expression, pembro alone could arguably be the reference standard. We have strong data for combination chemotherapy with immunotherapy. This was reinforced by Dr. Attenborough and his colleagues at this year's ASCO, an FDA analysis, essentially a meta-analysis of multiple trials showing a clear response and progression-free survival advantage for the combination versus immunotherapy alone. The conclusion for survival is a bit controversial. The hazard ratio is clearly favorable at 0.82, but the confidence intervals were wide and they did overlap unity, and many of them misinterpreted that, I believe, as a mark against the use of chemotherapy in this setting. I think it's an open question. I strongly believe in that question, and there is an ongoing trial called INSIGNA through the NCTN, the National Comprehensive Therapeutic Network in Cancer, comparing single-agent pembro to combination carbo-pembro in non-squamous metastatic wild-type non-small cell. And that study is accruing fairly well. Pace is picking up, and I think that will directly address this open question. There's a further question about how to select patients appropriately for immunotherapy. Are there other markers? KEAP1, STK11, or for that matter, KRAS. Dr. Nakajima, Dr. Attenborough's colleague at the FDA, did a similar analysis looking specifically at the role of both KRAS and PD-L1 on outcome, specifically on survival in patients receiving immunotherapy either alone or in combination with chemo. And the bottom line, response rates, survival was superior no matter the KRAS status. Intriguingly, in those who had KRAS mutation and also high PD-L1, there may have been a preferential benefit for chemo and immunotherapy. It's very small numbers, hypothesis generating, but it looks promising. The vast majority of our patients, at least historically, probably weren't great candidates for the clinical trials that established immunotherapy. So there was an important study, it was presented as a poster discussion during ASCO, but I personally think it probably should have merited plenary status, that compared the Ipi-Nivo combination, so a non-chemotherapeutic approach, to chemotherapy alone in both PS2 and elderly PS0 and 1 patients. And the trial had 2 striking, very divergent conclusions. Number one, PS2 patients were probably not well served by the immunotherapy combination. Their median survival was less than half that observed for chemotherapy. And unfortunately, their inclusion in this trial prevented the trial from actually achieving statistical superiority. On the other hand, in the larger elderly population, about 60-65% of enrollees with intact performance status, Ipi-Nivo proved superior to chemotherapy alone. In fact, the median survival nearly doubled in that population. In a subset analysis, the hazard ratio was below 0.7 and the confidence intervals below unity. And I think that really serves 2 purposes: to show that fit elderly do as well or nearly as well as fit younger patients, and that performance status trumps age. That if you have poor performance status, it does not matter what your age is, you're not going to do well on these therapies. And going forward, we need to do separate, discrete trials in both populations. Finally, in the second-line setting, we have very intriguing data from the LungMap trial. First positive outcome from that trial comparing combination ramucirumab, monoclonal that targets angiogenesis, with pembrolizumab versus state-of-the-art second-line treatment, generally docetaxel or docetaxel-rami, in patients who had been previously exposed to immunotherapy. And that trial showed a survival advantage, about a 3-month improvement. The p-value is right on the cusp at 0.05. And we're certainly looking forward to compendia approval. Very attractive combination, far less toxic than the docetaxel approach. We still will need prospective randomized phase 3 data to validate this approach. When it comes to targeted therapy, Charo Agarwal, Erica Carpenter, and Jeff Thompson at my institution looked at the role of liquid biopsy in combination with tissue biopsy at diagnosis, and with a retrospective cohort series of well over 300 patients over a 2-year period ending in late 2020. And we had 2 major conclusions. Number one, that if you do both, you're far more likely to get full comprehensive NGS testing, and that in turn translates into a survival advantage. Those who have full NGS, whether it's tissue or tissue plus plasma, have better outcomes compared to those who have incomplete or no testing whatsoever, and probably because of more appropriate use of targeted therapy and less inappropriate use of immunotherapy. And also, knowing the NGS results prior to treatment selection will also translate into a survival advantage. Finally, in the realm of small cell, we have the Antrim 005 trial from China, which evaluated yet another checkpoint inhibitor, serplulimab, in combination of platinum and etoposide versus chemotherapy alone. And like the Caspian trial before it, which looked at durva and chemo, or the Empower 133 trial, which looked at Tezo plus chemo, a clear-cut survival advantage compared to chemotherapy alone. Had the best hazard ratio of the set, under 0.70, but it should be noted that small cell in East Asia is not the same as small cell in North America and really the rest of the world. The patients diagnosed with small cell in East Asia for various reasons having to do with TMB, with lymphocyte sensitivity, may be a bit more likely to respond to checkpoint inhibition compared to their non-East Asian counterparts. So it's been a pretty heady year at ASCO, and a lot of very interesting trial results have unfolded, and I look forward to additional studies in this realm.